Now finally, we've moved on to the acyanotic heart diseases, and we'll start with congenital pulmonic stenosis. So these babies aren't going to be turning blue. They're going to have other problems. So what is congenital pulmonic stenosis? That means the pulmonary valve, which leads from the right ventricle to the pulmonary artery, is narrowed and stenotic, causing an increased resistance to right ventricular to pulmonary artery blood flow. So the pathophysiology, you have a stenosis of the pulmonic valve causing obstruction from the right ventricle to the pulmonary artery. Because you have increased resistance to the RV systole, the right ventricle will hypertrophy to try to overcome it, and eventually over time, usually in adulthood, it will fail. So you get right ventricular hypertrophy because of the obstruction. Usually congenital and found in children, but only causes problems when they're adults. So what are some signs and symptoms of congenital pulmonic stenosis? It's very similar to aortic stenosis, just on the other side. So you get the same syncope, angina, and dyspnea because the right ventricle is hypertrophying. You can't get as much blood to the left side of the heart, so you can get syncope because you're not getting as much forward blood flow. Dyspnea because not enough blood is going to the lungs, so you can't meet the metabolic demands of the body. And angina because the right ventricle will be so hypertrophied that it cannot get enough coronary blood supply, leading to chest pain. There's no pulmonary edema or hypertension. Why is that? Yeah, you'll have decreased pulmonary markings because you have a pulmonic stenosis. There's decreased blood flow into the lung, so you're going to have a pulmonic stenosis. You also get the right ventricular substernal heave. So what was a substernal heave again? Remember, it means that the right ventricle is so large that it's pushing the chest wall upward every time it fills and contracts. So the substernal heave is a sign of right ventricular hypertrophy. Important to know. You also get a parasternal systolic thrill at the second left intercostal space. The thrill is the forceful flow of blood through the pulmonary artery. It's a systolic crescendo decrescendo murmur at the left upper sternal border. That's the most important thing you want to know about this murmur. Remember, aortic murmurs are on the right upper sternal border, and pulmonic murmurs are on the left upper sternal border, especially with stenosis. It's louder with inspiration and valsalva release. In both of these, valsalva release means you let go of the tension that's contracting your muscles, and you get increased blood flow back to the right heart, and inspiration increases blood flow to the right heart too. So there's more blood in the right ventricle. You'll get a louder sound because of a greater pressure gradient. Prolonged splitting of the second heart sound. Why does that happen? Right, because the pulmonic stenosis causes a delayed contraction of the right ventricle through the pulmonic stenosis, and there's a longer time period of getting blood from the right ventricle to the pulmonary artery. And because of that, the aortic valve will close first, and the pulmonic valve will close second because of the long delayed contraction and moving of blood forward. You have a delayed P2 upon inspiration, just as we talked before. When you breathe in, there's more blood on the right side of the heart, more like pressure gradient, and more time it will take to equalize the pressure between the pulmonary artery and the right ventricle. Diagnosis, as always, echo is the best test you can do to diagnose this. And treatment is something called a balloon valvuloplasty, where you put a balloon in the pulmonic valve and open it up, and that helps it if it's symptomatic. So it's symptoms like right heart failure or the sad symptoms that we see here, syncope, angina, dyspnea. Now let's talk about congenital aortic stenosis. This is our second acyanotic heart disease. Pathophysiology is just like in pulmonic stenosis, you have a narrowing of one of the semilunar valves, this time the aortic valve. So you have a stenotic narrowed aortic valve restricting blood flow from the left ventricle to the ascending aorta. So you have decreased blood flow in the ascending aorta and a lot of increased pressure in the left ventricle. And what's that going to lead to? Increased resistance to systole and eventual hypertrophy of the left ventricle. Causes are bicuspid aortic valve, rheumatic fever, and idiopathic calcific degeneration. This happens in the very elderly people. Most elderly people are going to end up getting some form of calcification of the aortic valve. May not necessarily be a stenosis, but it does build up over time. You can have a bicuspid aortic valve, and if you have bicuspid valve, you will get the aortic stenosis symptoms, such as the murmur and problems and other effects, before 70 years of age. And if it's the idiopathic calcific degeneration, that'll happen after 70 years of age. As we talked about before, the left ventricle will hypertrophy because of the high pressure in the left ventricle trying to overcome the resistance of the aortic stenosis. So you'll get a very large left ventricle as a result, and EKG will show left ventricular hypertrophy. Symptoms and signs, just like pulmonic stenosis, is usually only presents in adulthood, and you get the same symptoms here: angina, dyspnea, and syncope. So once again, the reason why we get those is that the left heart cannot supply the entire body with proper oxygen and proper blood flow because of the severe aortic stenosis over time. So you get syncope because of decreased forward blood flow, angina because remember the heart supplies itself, so you have decreased blood flow to itself, the heart, and dyspnea because you cannot meet the metabolic demands of the body and you're trying to breathe harder and faster to get more oxygen. Left heart failure, diastolic. Remember, when you have a aortic stenosis, you get hypertrophy of the left ventricle. If you have a hypertrophy of the left ventricle, the problem is not systole. It can contract very well. It just can't relax because it's so thick and full of muscle. You also get arrhythmias. Why? Because you're decreasing blood flow back to the heart because the aortic stenosis is proximal to where the coronary arteries leave. And in addition, the left ventricle is so hypertrophied that the coronary arteries can't even supply it very well. And as a result, you're going to get arrhythmias due to damage to the electrical tissue. More signs and symptoms. We have a murmur, this time in the opposite part of the upper sternal border. The right upper sternal border, crescendo, decrescendo. Okay, so it gets louder until it peaks in the middle, and then it decrescendo, gets softer. Second intercostal space, right upper sternal border. It's also known to radiate to the carotids and associate with pulsus parvus et tardus. So this should be a P-U-L-S-U-S, pulsus parvus et tardus. You have a delayed and weak carotid and peripheral upstroke because of this aortic stenosis, decreasing the amount of blood that flows through the aortic valve. S4 heart sound. Remember, S4 heart sound is when the atrial contraction, the left atrial contraction, pumps blood into the left ventricle, and that blood hits the walls of a thickened left ventricle, such as a hypertrophied one, and creates a sound. And this will happen right before S1, so it'll be like the galloping horse, da-da-da, da-da-da, S4, S1, and then S2. Paradoxical splitting of S2 heart sound with inspiration. So the opposite thing happens now. In pulmonic stenosis, you had a longer splitting of the S2 heart sound because when you inspire, more blood would go to the right side of the heart. But when you have a aortic stenosis, the left side will always take longer to contract and longer to equalize in pressure before the aortic valve closes because of the aortic stenosis. So no matter what, whether you're breathing in or breathing out, you will always have the second heart sound of the aorta be before the second heart sound, be after the second heart sound of the pulmonic artery. So when you have paradoxical splitting, the P2 always closes first, A2 always second, no matter whether you're inspiring or expiring. And another key thing here is that if you have a normally split S2 with the P2 closing second and the A2 closing first, that means that you have aortic stenosis is not a diagnosis. You can exclude it. So remember, normally the P2 takes longer to close the inspiration than the A2. So if that happens, you definitely don't have aortic stenosis. And the best test of diagnosis, like always, echocardiogram. You will show EKG findings of left ventricular hypertrophy and STT wave changes. Ischemic, because remember, the left ventricle is so thick, it can't supply enough blood to itself. And the treatment, especially if they have the SAD mnemonic, any of these SAD symptoms, syncope, angina, dyspnea, they need an aortic valve replacement with balloon valvuloplasty or aortic valve replacement with a manual or a prosthetic valve. So now let's do another question. This will get us more back awakened because of all the material that we've been learning recently. So this will be about acyanotic heart disease. Which of the following will worsen the patient's condition? So we're talking about what will make this patient's condition worse. Key point. Exercise, beta blockers, nitrates, IV fluids, and septal ablation. So something's going on with the heart here probably. 19-year-old male athlete presents to the emergency room after a syncopal episode during a basketball game, so an exertional syncope. He has felt intermittent palpitations throughout his life, but never thought anything of it. He has a paternal uncle who died suddenly very early in adolescence, so we have a sudden death due to a cardiac condition, and he's awake and stable but scared. On auscultation, you have a systolic murmur at the left sternal border that improves with squatting. Left sternal border and improves with squatting. Interesting. So we'll talk about what that means in a little bit. Breath sounds are heard normal bilaterally. EKG shows left ventricular hypertrophy and STT wave changes. Patient's counseled to receive a defibrillator and requires a cardioprotective medication. So which will worsen the patient's condition? So based on what this patient has, because he's an athlete that had a syncopal episode and he has an uncle who's died suddenly, this must be an inherited condition that causes sudden death. Also, there's a systolic murmur at the left sternal border that improves with squatting. Squatting increases peripheral vascular resistance, and increases the amount of afterload that the left ventricle has to pump against, keeping the preload in the left ventricle increased. So this is all very classic for hypertrophic cardiomyopathy. And we'll talk about this in more detail and all of the systolic murmur and why it improves with squatting in the next couple slides. But which of the following will worsen the patient's condition? So mild exercise. So it's true that in hypertrophic cardiomyopathy, you want to avoid severe exertional exercise in competitive sports, but mild exercise is important for anybody to survive. There are very few contraindications to mild exercise, and hypertrophic cardiomyopathy is not one of them. Beta blockers. Remember, beta blockers are one of the most important medications we can give to a person with hypertrophic cardiomyopathy. And why is that? Remember, a beta blocker will prolong diastole by decreasing contractility and heart rate. So by increasing diastole, you will open up the left ventricle with more preload and move the hypertrophied septum away from the left ventricular outflow tract. And also this will help prevent the mitral anterior systolic motion as well. Nitrates. If you give nitrates, what happens? Right, you venodilate and decrease the preload to the heart. Would that make this condition better or worse? It would definitely make it worse. If you decrease preload, remember there's less blood in the left ventricle, so the septum, the interventricular septum, which is in between the right and the left, will be pushed over to the left, and that'll narrow the outflow tract and cause more of an obstruction and worsen the patient's condition. So we can hold on to nitrates. IV fluids will increase the preload and cause the obstruction to be alleviated because you'll have more preload in the left ventricle, pushing the septum away from the left ventricular outflow tract. And we'll see more pictures of this soon. Septal ablation. Will this worsen the patient's condition? No, because the septum is the problem. So septal ablation actually would be helpful in this patient. So that's why the answer has to be nitrates. Because by decreasing the preload, you will actually worsen the obstruction by causing the hypertrophied septum to block the outflow tract and also increase systolic anterior motion of the mitral valve and causes the patient's condition to get worse.